Good morning. My name is Henrik Kehlet from Copenhagen in Denmark. And thank you for the invitation to talk about and review enhanced postoperative recovery with the subtitle, Good from Afar, but Far from Good, ? And I will focus my talk on several topics. What was the concept from the very beginning? What are the pathophysiological challenges in the future? What are the problems around uptake of evidence-based errors? Then I will focus a little on post-discharge recovery, and finally discuss future challenges. So let's move forward to the concept and what are the results. So all the many hundreds or even thousands of publications now on errors have clearly shown that length of stay is reduced, that readmissions are not increased, that medical complications are reduced, and we have data from all over surgery, all specialties. Therefore, with all this presented and published evidence, the question is, what is the problem? And we have to go back to the start in the early 90s, where we asked from here 3 basic questions. First, can every operation be ambulatory? That means outpatient. And many can, but not everyone. And therefore, the next question is, why is the patient in the hospital? And apparently, since many surgical patients are still in the hospital, there is something we cannot really control. And these 3 questions are the important ones to remember every day when you go around and look at your patient. So when we ask the patient, why is the patient in the hospital and what are the challenges in postoperative recovery? It gets extremely complicated because there are so many factors to control. We start from the top here, organ dysfunction, the surgical stress response, hypothermia-induced morbidity. We have to avoid that. Pain problems, I will discuss, nausea, vomiting, and ileus, fluid problems, cognitive dysfunction and sleep disturbances leading to fatigue, immobilization-induced and semi-starvation-induced morbidity. Blood management is getting more and more important. Fatigue. Why are you tired after an operation? And finally, we have a lot of surgical traditions with use of unnecessary tubes, drains, restrictions, etc. And all these factors have to be considered, controlled, and modified in order to enhance outcome. So from the very beginning, when we published this, we illustrated that it is a multimodal approach. It cannot be solved by a single intervention. In the very center, we have pain management because sufficient pain relief is a prerequisite for having recovery. But then you have to move to post-operative care, and the nurses have to provide early mobilization and exercise, and then all nutrition facilitated by the reduction of nausea, vomiting, and ileus. In combination with these things, we have to attenuate the stress responses. I'll come back to that in more detail. And finally, as usual, preoperative optimization of organ dysfunction. That is not new, but the new thing here is a very detailed information to the patients about their participation in the whole perioperative recovery process, because they have to be active. And if you do this simple screen, which is more complicated, of course, you have enhanced recovery and reduced morbidity. So this is a busy slide, and I will not go into detail because that is the topics I will talk about. We have these different components, And this is reviewed in a very recent publication where you can go into more detail. So we have the stress responses, we have the fluid problem, we have the pain problem, the blood management problem, the cognitive function problem, autostatic intolerance. That means that patients cannot mobilize as they should, thromboembolic complications and reduction of risk, ileus, prevention, and then there is some psychiatric aspects where psychopharmacological treatment is really a care component that reduces recovery. So let's start with the basic mechanism of delayed recovery, and that is the stress response. This has been debated for many years. We know exactly that immediately when the knife comes in, you have two types of stress responses, the hormonal responses and the very difficult, complicated cascade system responses. Those two leads to increased organ demands and substrate mobilization and immunosuppression. And therefore, you will have a risk of organ dysfunction. And if you have organ dysfunction, you obviously will have a risk of the classical complications to surgery. And obviously, it's all about trying to reduce these undesirable responses. This is a difficult study, but it's so crucial to understand what is going on with these inflammatory immunological changes regarding recovery. So this study from Stanford in US looked at clinical recovery from surgery. Surgery was a hip replacement, and then they measured some very detailed changes in single-cell immune signatures. Now, the outcomes were very simple. Very simple. It was time to 50% recovery from fatigue, time to mild impairment of hip function, and time to achieve mild pain. And then they looked on all these three components here, the number of days it took to recover. And on the abscissa, on the x-axis, they had in this slide some of these inflammatory immunological changes. And you can see that for each outcome, there is a positive correlation so that the more pronounced the inflammatory and immunological responses were, the longer it took to recover. A surprising good correlation between these simple outcomes. Again, meaning that some patients who have an exaggerated inflammatory immunological response, they take a longer time to recover. And therefore, we should strive to modulate these responses. So the question is, how can we modify? We have three techniques. First of all, we need some help from the anesthesiologist by providing different neural blockades to inhibit the nociceptive stimuli going into the brain. And this is effective, as shown in many studies. It inhibits the endocrine metabolic responses. And of course, it's a powerful pain management principle. The second thing is the use of minimally invasive surgery, which has been shown, because of smaller wounds, has been shown to decrease pain, of course, and also inflammatory responses. In contrast to these techniques, they will not modify inflammation. Finally, we have new techniques, and they are important to add in certain patients, pharmacological modification, especially at this time, where steroids is the only important component, which also will reduce pain, nausea, vomiting, and the inflammatory responses. So back to the pain problem. That's a prerequisite to enhance recovery. It's very complicated. I could talk for several hours about it. The problem is, as you can read about in this little review here, we have to provide what we call dynamic balanced analgesia. And that means an effective analgesia allowing early mobilization and avoiding or reducing opioids. It has to be a procedure-specific approach, and you can find that on the Prospect website, a specific review on each type of surgery, what is the best pain management. And please remember, all this must be assessed in an ERAS setting. We have challenges in the future about pain management because we have to be more careful in our research to separate patients as normal pain responders versus high pain responders, as we also reviewed in this paper. So we have some papers that are characterized as pain catastrophizers. It's easy to assess, should be done, and also those who are receiving preoperative opioid because they have a much higher pain response than other patients. And therefore, we need a specific focus on these high pain responders in future trials. It hasn't been done except in a very few number of studies. Now, as I mentioned, cognitive dysfunction is a well-established side effect of major surgery, and especially in elderly patients. It's again complicated. It's a multimodal problem due to pain, due to opioid use, due to sleep disturbances, and to the inflammatory response. And these four factors, they are combined because inflammation leads to more pain. Pain leads to sleep disturbances. Inflammation leads to sleep disturbances. Use of opioids leads to sleep disturbances. And if you don't sleep, you will get tired and your cognitive dysfunction and risk of delirium will go down, will increase the risk. So therefore, the question is, how can we modify and improve? And that comes back to the ERAS concept, where you modify all the risk factors. We don't have so many studies on this. We have published extensively on fully implemented ERAS programs in hip and knee arthroplasty, showing that delirium is not a problem anymore, clinical relevant problem, if you do what the evidence tells you to do. And the same thing is happening in fast-track colonic surgery with a stay in open or laparoscopic surgery around 2 to 3 days. So we know how to proceed, but we need similar data from fully implemented ERAS programs in other procedures. Now, an important component of ERAS, which was not in the recommendations from the very beginning, is patient blood management. This is getting more and more important, and we have 3 pillars. The first one is to optimize preoperative anemia. That is well established. It leads to increased complications, lengths of stay, and readmission if you are operated with preoperative anemia. The next thing is intraoperatively to reduce blood loss, and that can be done by minimal invasive surgery and also the use of tranexamic acid, which should be standard of care. The last factor is postoperative anemia, and this is a rather black spot where we need more data to document, which has been done preliminary, that postoperative anemia is also a risk factor for sufficient recovery. And it's a multidisciplinary team approach and rather difficult to implement. I will show you one recent article from US, a huge database study on the role of postoperative anemia on cardiovascular outcomes. And this was a huge database study. They looked at anemia postoperatively for the first 15 days postoperatively, and they had a composite outcome on mortality, myocardial infarction, stroke, and acute kidney injury. And then they had 3 different groups of risk patients. Here on the abscissa, we have the lowest hemoglobin level, and here you have the probability of a complication. And you can see clearly that those patients who are anemic postoperatively, if they belong to the risk patients, they have a much, much higher risk of complications. And we have also shown that in postoperative myocardial infarction and stroke in really implemented fast-track hip and knee arthroplasty, that anemia is an important factor we need to control to further enhance recovery. Another very recent publication, again in hip and knee replacement here from Bone and Joint Journal a few months ago, the effect of severity of anemia is associated with 30 days complications. A huge, again, database study from US, the NESCIP database, but they haven't implemented errors. So they just have the huge database on patients, and they showed that moderate to severe anemia increased complications with an odds ratio of more than 5. So again, a safe conclusion and important. Preoperative anemia should be diagnosed and treated to achieve a good enhanced recovery program. Now, fluid management has been debated for many, many years. I think we all agree that giving too much fluid is dangerous and giving too little is also dangerous. Therefore, it has been recommended before to go for a 0 fluid balance, but this is dangerous because it increases the risk of giving too little. So the current recommendation is to achieve a positive balance about 1 to 1.5 liter. Remember again that even outpatients, ambulatory surgery, they need to have at least 1.5 liter of fluid without having any blood loss, etc., to enhance recovery. Small outpatient surgery. Now, the second thing is we need to use balanced solutions, not isotonic saline alone, well established. The use of colloids are still controversial. Goal-directed therapy is promising, but we need more error studies. Goal-directed fluid management is optimization of cardiac function pre and intra and early postoperatively. But the conclusion here is we need more fast-track studies on fluid management, but the basics are well established. So I told you about psychiatric disease. It's coming up in the world literature as a risk factor, which we haven't really looked at before. And we have many data published in fast-track hip and knee replacement. So it is well established that those patients who have been on antidepressant treatment before surgery, they have a higher risk of long stay and readmissions and higher risk of falling, etc. So the question is it due to the psychiatric disease in itself, or is it due to the psychopharmacological treatment in itself? And as we have shown, and this is the latest publication, it is probably the drugs and not the psychiatric condition in itself. And therefore, ongoing studies are focusing on these antidepressants. How can we stop them before the operation? We have also shown, because of the influence of antidepressants on thrombocyte function, that the risk of having a blood transfusion, if you are treated with these drugs, is increased. So again, an important topic for further improvements. Then we move to the other topic I told you about in the beginning, thromboembolic prophylaxis. All the guidelines show that this in major surgery, especially in major cancer surgery, should be continuous for up to several weeks postoperatively. And hip and knee replacement and abdominal surgery has been the classical models to show that it should be a prolonged prophylaxis. Now, the question, as we discussed some years ago, is that all these studies are with long lengths of stay and no implementation of errors. And therefore, they obviously have included the usual immobilization. And immobilization is one of the most important factors leading to thromboembolic prophylaxis. And therefore, the question is, what is optimal prophylaxis if we have a fully implemented ERAS program with sufficient mobilization already on the day of surgery? We have published that and studied it very detailed in the model of hip and knee arthroplasty, as I said, the classical model for recommending a prolonged prophylaxis. This study here, published 2 years ago, was a prospective follow-up study in a large consecutive group of patients where patients with lengths of stay less than 5 days, and now the median length of stay in all our multi-center study is 1 day with hip and knee replacement. That means they only get 1 dose of prophylaxis and not continuing postoperatively. These studies have shown that there is a very, very low risk of thromboembolic complications and even lower than with prolonged recommended thromboembolic prophylaxis. And therefore, the conclusion is that post-op prolonged thromboembolic prophylaxis in ERAS needs reconsideration, and probably we shouldn't use it as otherwise recommended. This article here again discusses all the controversies on the different recommendations on thromboembolic prophylaxis. It's not easy to be a clinician because there are so many recommendations, but this is a very interesting topic to reduce complications, and similarly, you save money by not using these expensive thromboembolic prophylaxis for several weeks. Now, a prerequisite, again, for early recovery is to mobilize the patients. Unfortunately, we have a pathophysiological response called postoperative autostatic intolerance. And we know, as this review have shown, and many of our studies, that in major surgery, 40 to 50% have problems to mobilize about 6 hours postoperatively because they get dizzy or may even vomit or faint. It is not a problem after minor superficial surgery like breast cancer, even major breast cancer surgery under general anesthesia for more than 2 hours. It's not a problem. So it's again related to these stress responses. We know from detailed studies that it is due to an impaired sympathetic response. When you mobilize, usually the vessels contract in the lower legs, and therefore you avoid blood accumulating there, and you keep the oxygenation and blood flow to the brain. This is the problem in some of these patients. We also know there's a strange increased parasympathetic response. We know that we cannot treat this autostatic intolerance with fluid. Detailed RCT published. The risk factors needs to be found out because we don't know for sure. It's probably related to use of opioids and most probably to the inflammatory responses. And therefore, the way forward is either a specific drug, which may work, and an alpha agonist, or use of steroids, where several studies are going on. So this is, again, an important factor to consider to further improve the concept of errors. Now, it all sounds good, and we have so many publications and the good results. So what is the problem? The problem is that we have a knowing-doing gap. We know so much, but that doesn't automatically lead to doing what we know from the scientific evidence. There is a slow uptake in different places, in different countries around the world, in contrast to the available scientific evidence. So this is a huge problem. Now, the ERA Society, they are doing a great job because they, from time to time, and they update it, they publish ERA Society guidelines on their website. And you can see here, they have guidelines in many, many types of surgery, which is a tremendous help for clinicians to be updated in what to do to enhance recovery and decrease complications. Despite all this evidence, the problem remains that implementation is slow. And why? That's a basic problem. One of the problems could be that the ERAS guidelines, and I don't go into detail, this is the ERAS guidelines colonic. There are so many factors they recommend you to consider and modify. And if you have to go out and modify, in this case, about 20 factors, you will always find some clinicians, anesthesiologists or surgeons who say, this is too difficult, I disagree, etc. And therefore you don't implement. Consequently, we have to focus on the few relevant factors to modify. And we have published repeatedly in the last couple of years what are the few factors. And I recommend you to go into to PubMed under my name and look at these publications to help you to focus on the simple factors to modify before you jump on a very complicated recommendation. For instance, in lung cancer surgery, the recent guidelines included up to 32 factors to modify. That's difficult. So the conclusion, as we published in JAMA last year, we have to have more focus on the procedure-specific understanding of the pathophysiology, the neurohumoral alterations, the volume homeostasis, the pain mechanisms, and use of minimal invasive surgery in each procedure. And this is important, to avoid recommendations based upon data from other surgeries. And that means in most instances, you come down to a few factors, 4, 5, 6, which is much more easy when you want to implement errors than having to discuss 32 factors. So please read these publications. And the recommendation, as I wrote some years ago in Annals of Surgery, errors, implementation, time to move forward. And we have known from the very beginning, more than 20 years ago, it's about reading the procedure-specific literature. That should be easy. You have to know your own data and compare it to the literature. But not everybody have their own data, unfortunately. You have to work together, anesthesiologists, nurses, surgeons, physiotherapists. That's not always easy in different places. You have to monitor your results and compare. And that's neither easy all places. Finally, and this is again important because you save a lot of money if you implement errors, you have to share the economic benefits. And we have described that in detail many years ago, Douglas Wilmore and I in surgery in 2008. So what are the other challenges? Well, we have to focus on 3 time periods when we discuss errors. The early one, going from surgery to the PACU to the ward. We need much more research on why should we stay in the PACU and what are the factors responsible for staying several hours there. The next one is the intermediate period from the ward until discharge. That's a conventional length of stay, nothing new. We have to be careful. It has been a good thing to monitor in the beginning, but the real future of errors is to focus on the late period, and that is return to normal function. Remember the word enhanced postoperative recovery. That's about the full perioperative course, not only hospital stay. So the problem here, because of the success of errors, is that many surgeons, they push to see if you can do even major surgery on an outpatient basis. This is just one example from last year, short-term outcomes of outpatient colectomy, outpatient colonic cancer surgery. A reasonable large study, 1/3 of them. Oh, what is happening here? 1/3 of them ended out to be outpatient. Length of stay was 10 hours, readmission few. So apparently it was feasible in some patients, but that's not the question. The question is it safe? Is it to be recommended? And I think it's all too early to recommend outpatient colonic resection in errors. Another example, laparoscopic nephrectomy as an outpatient surgery. Laparoscopic nephrectomy is not a big operation. It should be done as a 1 day, maybe max 2 days stay. But here they could do it in 92 of the included selected patients, and they were discharged within 6 hours. There were no readmissions. So what do we take from here? Well, apparently it's feasible in some patients, but should it be recommended? No way. We have to do much more studies to find out about the safety and the recovery. And finally, I take another example because this is a very popular operation now, a common operation, and it was just published in a good urological journal, Journal of Urology. And it's about a multi-institutional assessment of routine same-day discharge for robot-assisted radical prostatectomy. There were 6 centers in France with quite a number of patients. Same-day failure was only 4%. Fantastic. And that was more or less due to lymph dissection and also to pain problems. They had a large number of readmissions, mostly due to pain issues. So interesting publication. It is feasible. It may be safe, but we have to improve. We have to have much better pain management than what they had. And we have to agree on the selection for these patients. In our hospital, a youth center, the median length of stay after robot prostatectomy is 1 day, and it seems to be safe. So the question is, should we move to an outpatient approach? And we have discussed that in this article about 2 years ago, that outpatient total hip and knee arthroplasty, it is feasible. It is feasible in some patients. There are many reports from US and European countries. But we have to remember the concept of enhanced recovery is first better, then faster. And we have to know, especially in different risk patients, what is the ideal length of stay. And also, we have to be careful. We have to evaluate the cost reduction by same-day discharge compared to go home the next morning. Because if you go home at 7 o'clock in the evening, what happens to that empty bed? Is somebody coming in? So how much money do you actually save? This is an interesting discussion, and that applies to all types of ERAS surgeries. Finally, or not always finally, but most finally, ERAS, we know length of stay goes down, we know complications go down, medical complications. But ERAS is recovery, and therefore we have to focus on post-discharge function. And this, unfortunately, has not been done as much as it should. There are two ways to assess postoperative recovery after discharge, functional activity. You can do it objectively by measuring with different instruments the activity, or you can assess it subjectively with the patient-reported outcomes, which are so positive or so popular in these times. But the question is, what is the best and what is really reflecting reality of recovery? Now, as I said, there are many instruments to objectively assess. You can have these watch types instruments that can assess sleep and activity. You get it out. You can assess simple pre-enteral and postoperative, post-discharge oxygenation, and you can assess heart rate variability and Holter monitoring with very simple instruments. So we have the possibility to do it in an objective way. I will give you one example, but there are now at least 10 studies, especially in hip and knee replacement, comparing early patient-reported outcomes versus objective function after hip and knee arthroplasty in a fast-track setup. So here we have the physical function assessed, and the blue line is the patient-reported outcome with a well-established assessment. And these patients, they are positive 2 weeks after a hip, but it's the same 3 weeks after a knee replacement. The patients are satisfied. They rate themselves as being returning to activity in a positive way. If you measure it objectively by the number of minutes, seconds it takes to walk 40 meters, it goes down by about 20%. If you measure objectively with actigraphy the activity of the patients, it goes down 25%. And if you measure the number of seconds it takes to walk 9 stairs up, it goes down 62%. So, in other words, the patients are happy, but they cannot perform. And therefore, the question is, what is right? We looked at that in very detail in the second publication in these patients. And this is a complicated slide. I will only show you in one activity level that preoperatively they have a certain amount of activity. Of course, on the next day, they go down. That's expected. And here you have the recovery over the next 3 weeks. So you see, in general, a slow recovery, but they are not coming up to preoperative level within 3 weeks, despite receiving physiotherapy. And more importantly, about 25% had a continuous decreased activity over these 3 weeks. This study was not powered to show for sure what was the reason for not recovering, but it suggested that the risk factors were pain and the early inflammatory. So now we know we need to go for these factors in order to speed up recovery. And that may probably relate to other types of surgery. Another similar publication in a smaller operation, this is a cesarean section, recovery of physical activity and its relationship with pain. So here you have the relative pain score. If you're up here, you have much pain, and here you have the relative dip, low. If you're out here, you're really active. So you see the correlation. So the more pain you have, the less active the patient. It may be considered relatively simple, but that type of studies are important to understand where are the recovery problems. And obviously here it is pain, because cesarean section is not a huge operation and doesn't have so many complications. And that leads us again to prehabilitation. That means that you look at the patient preoperatively and make the rehabilitation before the operation in those patients who are frail and with limited function. It is obvious, it is rational, and we have more and more studies. And this one is the latest one, an updated review. The problem is that the preliminary data are positive, but the compliance from the patients to do prehabilitation is a problem. And we have to have more data. We have to have a more conclusive procedure in patient studies before we can spend money and time for prehabilitation in those patients who need it. Unfortunately, it is quite controversial. Franco Carli, who is a dominant researcher here from Montreal, he very recently published in JAMA Surgery his recent efforts in prehabilitation in colonic cancer patients. A rather small and difficult study performed in 2 centers over a couple of years, and it was negative. They couldn't show the benefit of prehabilitation. So this is controversial. We need more data. And another important topic where we have some very inconclusive data is, can enhanced recovery change oncological outcomes? Because if you have a medical complication, you know that long-term survival is also decreased and it may influence oncological outcomes. A recent publication with one of the ERA centers in US and Europe, it's a retrospective study. It's quite large. It's not randomized. They suggest that enhanced recovery programs reduce morbidity, but there is no overall disease-specific 5-year survival. So, sorry, again, very controversial, but promising, and it has to be studied in fully implemented enhanced recovery program in oncological cancer. Now, the last important topic for this talk is really, how do we make progress scientifically? And you know, there is a current trend to do and recommend very large clinical studies, very large RCTs, because the pathophysiological factors are so complicated, and therefore you need to do large randomized studies. They are required to reliable detect moderate size interventional effects that can have a substantial impact on health. For instance, a pain management, minimal invasive surgeries, fluid management. So this is a common trend. The problem is that almost all of these large pragmatic RCTs are negative, meaning that they couldn't show an effect. And Dan Sessler, who is one of the prominent researchers here, published a critical minor review about this. And I agree with him. We shouldn't call them negative, but we have to remember they didn't show an effect of the intervention. And therefore, the question is, if it was a rational approach and it was a huge RCT, what was the reason? And again, we discussed that 2 years ago. Large, pragmatic, randomized controlled trials, are they really the gold standard? And that's a very important problem when you read the literature and when you perform scientific studies in perioperative medicine. In my opinion, it's amazing that all these studies never ever discuss ERA's implementation. But it's obvious from their data they haven't done it. We shouldn't do large trials, in my opinion, and it's controversial, but that's my opinion. Large trials with low ERA's adherence has a waste of time, is waste of money. We should focus more on organ and procedure-specific functional recovery parameters first, and then do detailed pathophysiological studies on recovery with a given intervention, and then, based on these results in a fully implemented program, then conclude either to do a large RCT or a multi-center prospective studies. Very important, running controversial discussion about how to proceed this. So my conclusion here in advancing surgical outcome research and quality improvement within an enhanced recovery. Please read this short article because it summarizes most of what I've said. First, you have to understand the pathophysiology of postoperative organ dysfunction and recovery on a procedure-specific basis. Then you have to implement procedure-specific evidence-based perioperative care. It must be based on a multi-center collaboration, and then you have to monitor the procedure-specific outcome data, use established complication score systems, separate between direct surgical complications, could be a major bleeding, it has nothing to do with errors, and specific medical complications that like pulmonary or thromboembolic complications, which is about errors, and find out what is the time course. Finally, you have to formulate research topics, identify areas for improvement, and assess new treatment strategies. And you have to find out conventional risk factors. Are they important in an enhanced program? And then again, you start where you start. You begin again where you started, because there will still be challenges for improvement of the whole course, especially in major surgery. I will give you one example to finish. Hip and knee replacement. We got a lot of money to work together in many orthopedic centers in Denmark, across the country. These centers covers about 50% of the Danish activity in hip and knee replacement. What has happened? We had a scientific collaboration with meetings 1 or 2 times a year. We did more than 180 scientific publications on interventions and follow-up within these 8 years. Here you see the results from 2010. And the blue line is the median length of stay. It was 3 days. And then because of the collaboration and improvement, in 2017, the median stay was 1 day. The proportion of patients staying more than 4 days from here in the beginning was about 10%, and over the years it decreased about 5%. 50% reduction. All the complications have been reduced, and we are doing outpatient procedures in the well center. So an example on how to organize and improve in your enhanced recovery program, multidisciplinary and a multi-center. This is not RCTs to show all this, but it is based upon RCTs on specific interventions in fully implemented errors. So to finish up, we talk here on enhanced postoperative recovery, good from afar. Yes, it is good, but it is not totally far from good because we still have challenges. We have to focus on the pathophysiology of recovery. We need to have better procedure-specific evidence for the optimal simple errors component. We need to have an improved study design when we improve errors. And very importantly, we need to have better implementation of all the evidence we have. So please remember, the concept of errors is first better and then faster, not the opposite, not going too fast, not having too much cowboy surgery. It is all about patient safety, mobility, and recovery after discharge. Thank you very much.